Hello, my friends. Welcome to our third cardiac lecture. Now, this one, as you can see right down here in the corner, only 14 slides. So I'm going to make sure that I go through this rather quickly. So that way you don't have to sit through another 45 to 50-minute lecture like part two. So anyway, cardiac output. Cardiac output is a term, a very important term that's, if you look at it in equation form, CO equals HR times SV. Now, what exactly is this? It's the volume of blood pumped out by the ventricles in 1 minute. So we've got a time factor here in heart rate and a volume factor here with stroke volume. Remember, stroke volume we introduced in the second lecture. Stroke volume is the difference between EDV and ESV. So stroke volume is literally how much is pumped out per ventricular ejection. And so if you take that volume and multiply it by how many times the heart beats per minute, cardiac output literally is the volume of blood pumped out by the ventricles every minute. On average, 5 to 5.25 liters a minute. Okay, now, depending on how fast your heart is beating, cardiac output actually does change. So when we're at rest, there could be something called maximal cardiac output. Actually, no, sorry, not when we're at rest, but when we're at rest, cardiac output, yeah, roughly 5 to 5.25 liters a minute. But let's say if you're a non-athletic person and you're working out and your heart rate goes up, cardiac output's definitely going to go up, maybe to 20 to 25 liters a minute. Does that mean that your heart actually or your body made that much more blood? No, it doesn't. It's just pumping out more and pumping harder, per minute. However, with some trained athletes, their cardiac output can actually go up to be quite a bit more because their heart is figuratively a well-oiled machine. And so what we're going to do in this lecture is talk about cardiac output and talk about the various factors that affect it. And so how we're going to approach that is we're going to break it down and talk about the various factors that affect stroke volume, and then the different factors that affect heart rate, and then you'll be able to have develop this bigger picture for how changes in single variables actually have an overall impact on cardiac output itself. So again, let's focus on the factors that affect stroke volume. But real quick, as a review, remember stroke volume is EDV minus ESV. EDV, end diastolic volume, how much is in the ventricles right before they contract. ESV, how much is there after they contract. So stroke volume is the difference of that. And again, remember, stroke volume is how much blood the ventricles pump out per ejection. And on average, we're told that it's roughly 70 milliliters a beat. Okay, so 70 milliliters per ejection. Now, the three main factors that affect stroke volume directly are preload, contractility, and afterload. All right, so we're going to take them one at a time. Preload is referring to the degree of stretch on the myocardium. And remember, I talked a little bit about this in the second lecture. When the ventricles fill up with blood, the presence of the blood forces the ventricles to stretch. And whenever you stretch muscle, like we saw in skeletal muscle, there's a length tension relationship going on, both in skeletal muscle and cardiac muscle. And if you remember from our muscle lectures, whenever you put skeletal muscle in a slight stretch right before you contract it, you maximize cross bridge formation. And if you maximize cross bridge formation, remember, more cross bridges equals more force. So literally preload is the degree of stretch that the myocardium is placed in right before it actually contracts. So if the ventricles fill up with more blood, they stretch more. And if they stretch more right before they actually contract, guess what? They contract with more force. And if they contract with more force, stroke volume is going to go up because they've pumped out more per ejection. So if EDV goes up, that means there's more blood in the ventricles, therefore they stretch more. And so when they pump more out, that means that stroke volume actually goes up. And also ESV is probably going to be a little bit less compared to normal because, again, the ventricles pumped out more. So if EDV goes up, guess what? Stroke volume goes up as well, because if there's more stretch, there's more cross bridge formation. And if there's more cross bridges, there's more force. Okay? So anything that increases preload increases stroke volume. So maybe if the heart is beating just a little bit slower and the ventricles have more time to fill up with blood, that's an increase in EDV. And they're going to stretch more and then contract, boom, pump out more per ejection. Or an increase in heart rate can do that, because if there's more blood coming back to the heart, time-wise, that's going to stretch the ventricles. And if they're stretched, preload goes up and they contract with more force. Okay, so anything that increases preload increases stroke volume. Anything that increases stroke volume increases cardiac output. Okay, so and we can connect the dots even more and to say that anything that increases preload increases cardiac output. Anything that decreases preload decreases cardiac output. Okay, now, like I've been saying, in terms of the amount of blood that gets back to the heart, if the ventricles fill up with more blood, preload goes up. And so the amount of blood making its way back to the heart is actually called venous return. Okay, venous return. I mentioned a couple factors that affect that. But again, if more blood gets back to the heart, it's going to get into the ventricles. If venous return goes up, EDV goes up, and the ventricles stretch, we get a more forceful contraction. A couple of things down here, just some examples of things that would increase or decrease preload. Fluids, an increase in bodily fluids, like, and I don't mean bodily fluids in a negative connotation. I mean, let's say if you're dehydrated, or like sometimes when you go to the hospital for something and you get an IV. Okay, an introduction into fluids like that is actually going to increase the amount of fluid in your blood, and that's going to make, if there's more blood by volume in your body, that's going to cause the ventricles to stretch more. Sympathetic stimulation, okay, like during a fight or flight response, that'll do it. Or vasoconstrictor drugs. If you constrict your systemic vasculature, there's going to be more blood getting back to the heart, because not as much of it is getting out to the blood vessels. Or decreasing preload, something like a diuretic. Okay, diuretics. If you're urinating more, there's less fluid in the blood, therefore less blood getting back to the heart. Or vasodilating drugs like nitroglycerin. If you increase the diameter of your systemic vasculature, there's more blood flowing through the vessels at any given moment, and that means less kind of getting back to the heart. So medications can actually play a pretty big or substantial role in regulating preload. Okay, so preload is the force of ventricular contraction, but again, depending 100% on ventricular stretch. Because remember, more stretch equals more cross bridges equals more force. All right, now moving on is contractility in terms of factor number 2, regulating stroke volume. Contractility is different than preload. We're still dealing with the force of ventricular contraction, but contractility is the force of ventricular contraction at any given muscle length. So it doesn't depend on stretch. It's independent of stretch. So the ventricles don't necessarily have to stretch more if contractility is going to go up. Now, contractility is generally going to be something that's affected by calcium levels. Okay, and if the ventricles, or let me stop there for a second. So if calcium levels are increased in the blood, okay, that's going to cause the ventricles to contract with more force, again, regardless of how much they're being stretched. And if the ventricles contract with more force, again, that means that stroke volume is going to go up. If they're contracting with more force, they're pumping out more per beat. And if they're pumping out more per beat, guess what? There's going to be less in the ventricles left over, which means that ESV is actually lowered. So if contractility goes up, yeah, stroke volume goes up. There's more pumped out, and it means there's less left over. And like I said, that's generally because of more of more calcium being involved, because remember, more calcium equals more cross bridges, and more cross bridges equals more force. We saw that in skeletal muscle material, and we saw it here as well. Now, there's a term right here called an inotropic agent. And an inotropic agent is anything that changes contractility. Okay, so again, if I quizzed you or put a question on the test, and let's say I phrased it, which of the following terms refers to anything that changes contractility? That is an inotropic agent. Okay, now that's a general term of anything that changes contractility. But if you think about it, can we increase contractility? Absolutely. Can we decrease it? Absolutely. So anything that increases contractility, we would call a positive inotropic agent, or a positive inotropic factor, or I've heard it called a positive inotrope. So anything that increases contractility will be a positive inotropic agent. So epinephrine, for example, is in that category. High extracellular calcium could be in that category as well, because remember, if there's more calcium, more cross bridges, more force. The reason that epinephrine actually acts as a positive inotropic agent is because more epinephrine actually facilitates more calcium getting into the myocardial cells. So that's why epinephrine would actually do that. So during a fight or flight sort of situation, when there's more adrenaline circulating through the body, adrenaline and epinephrine are the same thing. That's why your heart could beat with more force. That's why your blood pressure might go up during a stressful situation, is because of that. So more epinephrine leads to more calcium getting into the myocardial cells. Or if you have hypercalcemia, every time, like we talked about in the part 2 lecture, every time during that plateau phase, if there's more calcium in the blood, more calcium is going to get into the myocardial cells. And again, more calcium, more cross bridges, more force. A negative inotropic agent is anything that decreases contractility. Okay. So for example, a calcium channel blocker. I think we mentioned this in the second lecture. So if you decrease the amount of calcium that gets into the myocardial cells per plateau phase, you're going to not minimize, but just decrease the amount of cross bridges that are formed, and make the ventricles contract with less force. Okay, so contractility again is the force of ventricular contraction independent of stretch. So do preload and contractility have anything in common? Yes, they do. They both refer to changing ventricular force, that how forcefully the ventricles are contracting. The biggest difference is preload depends on stretch, contractility does not. Okay, now the last thing I need to mention in terms of factors regulating stroke volume is afterload. Now, afterload is the back pressure exerted against the semilunar valve walls generally because of the blood that is in the two great vessels. So remember, when the pulmonary trunk contracts, it sends blood through the when the right ventricle contracts, it sends blood through the pulmonary valve into the pulmonary trunk. When the left ventricle contracts, it sends blood through the aortic valve into the aorta. And when the blood is there, and the pressure in the great vessels increases above ventricular pressure, it shuts the semilunar valves. And the pressure in the two great vessels at that time is afterload. So that back pressure against the semilunar valve walls. And so, when we're talking about preload and contractility, we're talking about things that change ventricular force. And anything that changes ventricular force is actually going to change blood pressure. This is kind of an interesting situation here, because afterload is actually the pressure that the ventricles actually have to overcome just to get the blood out. So under normal circumstances, the left ventricle has to overcome 80 millimeters of mercury just to get it open, to get the blood out. And the pulmonary trunk has to overcome a much less pressure, 10 millimeters of mercury, to get the blood out, going to the lungs. And so if you think about it, this is diastolic pressure. So under normal conditions, it's not that big of a deal. the heart can easily overcome, each ventricle can easily overcome these pressures and get the blood out. But if normal pressure, let's say, is 120 over 80, what if a patient has a blood pressure of 160 over 120? Now, the left ventricle, under normal conditions, just has to overcome 80 millimeters of mercury to get that aortic valve open. But if a person's diastolic pressure is 120, that means that the left ventricle now has to use much more energy just to get the valve open. And that means that there will be less energy to push blood out, and actually less blood will get out. So actually, if afterload is higher, stroke volume is actually going to go down. And so that is a pretty big deal when you think about it, because if there's less blood getting pumped out per ventricular ejection, less blood is getting to the lungs to get oxygenated, less blood is getting back to the left ventricle to then get pumped out to the body. So afterload is now a big deal. So if afterload is higher, okay, if afterload increases, stroke volume goes down. It's an inverse relationship. With preload and contractility, it's a direct relationship. If preload and contractility go up, stroke volume goes up. If they go down, stroke volume goes down. Here it's the opposite. If afterload is high, stroke volume goes down. If afterload is lower, stroke volume is higher. So it's just about how much pressure the ventricles have to overcome to get their blood out. So factors increasing or decreasing afterload are listed here. So if we want afterload to go up, okay, like vasoconstrictor chemicals or medications will do that, because if you increase the resistance, what's called vascular resistance of blood flowing through the vessels, that's actually going to make pressure in the two great vessels go up and make it harder or make the blood pressure go up because of the heart having to pump harder just to get those valves open. Or if you want afterload to go down and you want that diastolic pressure to go down, vasodilating medications will go down, because that will actually decrease vascular resistance and make it easier for blood to flow through, and therefore pressure in the two great vessels is going to go down. Okay, so preload, contractility, and afterload are all going to affect how much blood the ventricles are pumping out per beat. Okay, now I'm not going to show it to you, but I love this video. This is a great video. I can't remember what her name is. I think it's Sarah, Nurse Sarah, but she does a great job explaining preload and afterload. And what's even better is she's got a great Southern accent. I'm a sucker for a good accent, whether it's Southern. I love a good Australian accent, a good British accent, whatever it is. I love a good accent. And so she has a great Southern accent, and she does a really good job explaining this. So I would definitely encourage you to watch that in your own time. All right, now let's get on to factors regulating heart rate. Okay, so stroke volume and heart rate. Okay, so those are going to be the main factors that affect cardiac output. Now, anything that changes heart rate is going to be called a chronotropic factor. Okay, so chronotropic factors, let me just let's add this here, a little real-time editing. So, I don't want that in, I will leave it italicized. So chronotropic factors, okay? So chronotropic factors are anything that change heart rate, okay? So chronotropic factors are anything that will change heart rate. All right, now, so a positive chronotropic factor or positive chronotropic agent, or even a positive chronotrope, is anything that makes heart rate go up. A negative chronotrope or chronotropic factor is anything that makes heart rate go down. Okay, things like the autonomic nervous system, chemicals, and other factors which we'll get to. So there's a variety of things that actually can influence heart rate. The most profound one and important one that influences heart rate on a daily basis, moment by moment basis even, is the autonomic nervous system, okay, the ANS, which, if you remember from anatomy and then from one of our very first neuro lecture, the ANS is a subdivision of the peripheral nervous system. And in the ANS, we have the sympathetic and parasympathetic nervous systems, the SNS, okay, sympathetic nervous system, and PNS, parasympathetic nervous system, which PNS is also peripheral nervous system, so you just make sure you know which one is which. Okay, now, the sympathetic nervous system, and if you remember from the second cardiac lecture, the cardiac control centers are in the medulla. Remember the cardio-acceleratory and cardio-inhibitory centers. So if the cardio-acceleratory center in the medulla sends impulses along the sympathetic cardiac nerves to the SA node, AV node, and Purkinje fibers, they will release epinephrine and norepinephrine. Those will cause the heart rate to go up. How they do that is they facilitate more calcium entering the SA node cells during the depolarization phase of that particular cell type. And if that happens, the cell will depolarize at a faster rate. So if our SA node cells are depolarizing more rapidly, that means the heart will beat faster. So anything stressful, anything that mimics sympathetic stimulation, whether it's an actual increase in neurological stimulation, or if it's any sort of medication that mimics sympathetic stimulation, it will make the heart rate go up because of facilitating more calcium entering the SA node cells, again, causing them to fire or depolarize more rapidly. Flip side is if we get any sort of information or impulses from the cardio inhibitory center in the medulla. Remember, those go through the vagus nerve, cranial nerve 10, to synapse with the SA node and AV node, and those fibers will release acetylcholine, which we can see right there. Remember, that is abbreviated ACH. Oh, no. There we go. Acetylcholine. Now, acetylcholine hyperpolarizes the SA node cells by opening potassium channels and causing them to repolarize more rapidly. So it's going to actually slow down the heart rate, not affecting contractility, but it will slow down heart rate. And so again, information or impulses from the cardio-inhibitory center will slow down the heart rate. And also, if you think about any sort of drug or medication that would mimic parasympathetic stimulation, that will also slow down the heart rate. Now, no, let me see. I'm going to get rid of that because I should have did that earlier. My apologies. All right. Now, we're actually just about done, believe it or not. Okay, now, outside of the autonomic nervous system, anything else, I just kind of made a short list here of factors that would influence heart rate. And I've kind of been talking about this, but various chemical factors like epinephrine, norepinephrine, or there's a hormone produced by the thyroid gland called thyroxine. And I never remember, I think it's T3. There's two big thyroid hormones, I believe called T3 and T4. And I think thyroxine is T3. I should have looked that up. But chemicals like these, epinephrine, norepinephrine, are going to increase heart rate. Thyroxine increases heart rate. Those are going to do it. There's other chemicals as well that could do it. Like caffeine, for example, is something that could increase heart rate. Maybe on the flip side, things that would decrease heart rate might be alcohol. Okay, alcohol is a CNS depressant. It's going to slow down CNS function. And remember, our medulla is in the CNS, so alcohol could actually slow down heart rate. We've already been mentioning medications or drugs. So whether they are legal or illegal drugs could influence heart rate. Opiates could slow it down. Stimulants like methamphetamine, heroin, cocaine, they could all increase it. So the point here is that there are other things other than the autonomic nervous system that could do it. Now, exercise will increase your heart rate while you're exercising, obviously. But what could regular exercise actually do to your resting heart rate? So when you're in the moment and you're working out, whether you're lifting weights, you're going for a bike ride, a swim, maybe you're doing a spin class, whatever you're doing, when you're exercising, obviously there's increased metabolic demands placed on the heart to get blood out to circulation. So your heart rate's going to go up during exercise. But if you engage in regular exercise over time, that's actually going to make your heart work more efficiently and you're actually going to lower your resting heart rate. So exercise will increase your heart rate in the moment, but over time it'll lower your resting heart rate. So there's a little bit of a difference there. Uh, body temperature, body temperature actually can increase or decrease your heart rate. So when your body temperature goes up, your heart rate goes up. Okay, when your body temperature goes down, your heart rate goes down. So perhaps one of the dangers of hypothermia is a decrease in heart rate. And if your heart rate goes down during hypothermia, guess what? Warm blood is not getting pumped out to the body like it should. And so your body, as your temperature is going down, oxygenated blood isn't going to be making its way back out or back to where, or out, I'm sorry, to where it should. Now, I just left this in here and we talk about this generally in class. In the quote other category, maybe we add things like stress, that it isn't temperature related, chemical related, or exercise related. Emotional factors could actually increase or decrease the heart rate. So stress is not a good thing. Well, I shouldn't say that. Sometimes stress can be good, if it pushes us to, improve ourselves or pushes us to achieve a goal. But, unmanaged stress, you guys know this, unmanaged stress could actually be detrimental to our health. So stress, I would put that in here, and maybe it's positive or negative. And same thing with just general emotions, happiness, laughing. When you're laughing it up and having a good time, your heart rate might go up because you're laughing and it stimulates an increase in heart rate. So yeah, emotions could do that. Whether it's positive emotions or negative emotions. Maybe sleep. Okay, sleep. Taking a nap or just your average night's sleep will make your heart rate go down. And then things that obviously we're not going to get into, but like things that everybody deals with, sexual activity, sexual stimulation would make heart rate go up, which from a health perspective and with certain medications like that you see on advertised on TV or social media, I'm thinking of like erectile dysfunction medications like your Viagra, Cialis, Levitra, and all those things. Every time you see a commercial for one of those on TV, there's probably going to be a tagline in there that says, only use if your heart is healthy enough for sexual activity, because those are generally have a vasodilating effect, and that could actually lower blood pressure. But sexual activity, that stimulation might make your heart rate go up, or will make your heart rate go up for sure. And if drugs are vasodilators, if your blood pressure is low and your heart is beating fast, that could actually cause an unsafe drop in blood pressure. So it's kind of a potentially dangerous situation. So there could be, like I said, any number of things there. Okay, so actually, I think that's about it. But there's one thing that I want to go all the way back to this. And normally this is something that I have on the board when we're doing this live. But you want to let me kind of type this in down here. So if we look at cardiac output in equation form, okay. So heart rate times stroke volume. So I like to change colors and make things bold. And if you haven't noticed, any colors that I use in my handouts are generally the colors of various Star Wars lightsabers, of course. And red is my favorite. So anyway, so when you look at it in equation form, okay, and we talk about this as related to mathematics, if this number goes up, okay, if this number goes up, this number here will go up. If this number goes up, then this number goes up. But what if, let's say this number were to go down? let's say you sustain an injury and you're losing blood. If you're losing blood, the heart isn't pumping out as much per beat, so this number goes down. But if the body wanted to maintain cardiac output as close to normal as possible while we are losing blood, what would have to happen to this number? So if this number drops and the body wants to maintain this number is going to have to go up, interestingly enough. So you kind of have to think about this from a different perspective when you start thinking about injuries like that. Okay? So think about it from a mathematical perspective. Anything that changes this number or this value is going to affect this. Anything that changes this affects this. So ask yourself, if you go back and watch this lecture a second time, what happens to cardiac output if heart rate goes up? If you're stressed and your heart rate goes up, your heart's pumping out more per minute. Okay. If you lost blood because of a severe laceration, okay, cardiac output will go down unless the heart beats faster to compensate for it. So again, kind of a big picture health application to cardiac output now. So anything that changes these variables changes this. Okay? If you have questions, let me know.